Hi, everyone. Thank you for joining us today on Prescriber podcast. Today, we will be discussing the evolving world of healthcare beyond conventional medicine. Specifically, we're exploring the role of complementary and alternative medicine, also called CAM, in pediatric ADHD, an area that continues to grow as families seek more individualized and holistic approaches to care. As clinicians in an area of precision medicine and pharmacogenetics, it's essential to understand not only conventional pharmacologic therapies, but also the growing use of non-traditional approaches. Today, we'll explore the evidence, safety considerations, and potential interactions between CAM therapies and standard ADHD treatments. We will also discuss how treatment does not have to be one size fits all and ways to combine conventional medicine with alternative therapies. Before we begin, I want everyone to go ahead and introduce themselves. I'll start. My name is Morgan Zickney, and I'm currently in the dual acute and primary care pediatric track and graduating this December. Working with children daily, this topic is very important to me. I'm joined by Lindsay and Natalie and our special guest Danielle, who is here to help provide more insight on this topic from her personal experience. Lindsay, I'll let you take it over from here.
All right, thank you. Hi, I'm Lindsay. I'm currently in the pediatric primary care track, and I'm set to graduate this summer. I also care for children each day and believe this to be a very influential topic for discussion.
Hi, I'm Natalie. I'm a dual board certified pediatric and psychiatric nurse practitioner, and I work in outpatient psychiatry across the lifespan. And we definitely see a lot of children. Um, and I am in the MS and the DMP tracks done in August. And I would like to introduce our special guest who will be assisting us in this topic. Her name is Danielle Lettieri. She's a dual board certified nurse practitioner in psychiatry and pediatrics. She's currently working at Baker Pediatrics in Land O'Lakes. Hi, Danielle. Thanks for joining us today.
Hi, everyone. Thank you so much for having me. Like Natalie said, I am a dual board certified nurse practitioner for over 10 years. I have a strong background in both medical and behavioral health care, and I spent a large part of my practice helping children with ADHD, anxiety, developmental concerns, guiding families through the evaluation, treatment, and support process.
So, obviously, you have lots of experience treating children, and we appreciate your professional experience regarding ADHD treatment. How many children do you see and treat for ADHD?
I would say about 20 to 40% of my patient population um, is made up of ADHD, which is about 25 visits a week between evaluations and follow-ups.
Okay. Approximately 1 in 9 children in the United States, about 11%, have been diagnosed with ADHD, making it one of the most common neurodevelopmental disorders in pediatrics. Is this a condition it is a condition that all of us will see that we'll treat in practice. In your opinion, why is it especially important right now to revisit how we think about ADHD care in the pediatric population?
I think it's especially important right now because what we're seeing in pediatrics has really shifted over the past few years. ADHD isn't just about hyperactivity or trouble focusing in school anymore. It's showing up in more complex ways, often alongside behavioral health issues like anxiety, emotional dysregulation, sleep issues, sensory challenges. And at the same time, kids are growing up in a very different environment with more screen exposure, less structured routines, and higher overall stress levels.
That is true. Before we begin discussing the different treatment modalities of ADHD, I do just want to review what the gold standard of treatment is according to the American Academy of Pediatrics. The recommendations for treatment differ based on the age of the child and involve behavioral interventions as well as medications, either stimulants or certain non-stimulant medications. For children's ages 4 to 6, parent training in behavioral management is recommended as first-line treatment and includes behavioral classroom interventions if available. If these interventions do not provide significant improvement in behavior and there are risks of harm to the child if medications are not started, then methylphenidate may be considered.
And also, for elementary and middle school children aged 6 years to their 12th birthday with ADHD, the primary care provider should prescribe FDA-approved medications for ADHD, along with parent training and behavioral management and/or behavioral classroom intervention, preferably both. PTBM, and behavioral classroom interventions. Educational interventions and individualized instructional supports, including school environment, class placement, instructional placement, and behavioral supports, are a necessary part of any treatment plan and often include an IEP or a rehabilitation plan or 504 plan.
For adolescents aged 12 years to the 18th birthday with ADHD, the PCC should prescribe FDA-approved medications for ADHD with the adolescent's assent. The PCC is encouraged to prescribe evidence-based training interventions and/or behavioral interventions as treatment of ADHD if available. Educational interventions are similar to what Lindsay discussed. Now we have discussed the AAP guidelines. Danielle, what pharmacological and behavioral therapies do you typically use to manage ADHD? Based on your experience, what are the effects of these interventions?
In my practice, I really take a multimodal approach, and I believe that aligns with the American Academy of Pediatrics guidelines because there's no one-size-fits-all treatment for ADHD. So typically, I combine both behavioral strategies and pharmacological interventions based on their age, symptom severity, family preference. On the behavioral side, like you guys had mentioned, parent training and behavioral therapy are first line and key, especially in the younger children. I spend a lot of time talking with families about structure, consistent routines, positive reinforcement, setting clear expectations. From a medication standpoint, stimulants are first line, like methylphenidate or amphetamine-based medications, and they're very well studied. In my experience, it can make a significant difference in attention, impulse control, and overall functioning.
Excellent. Do you find that any parents are hesitant to start medications like stimulants due to the side effects like appetite suppression or sleep issues? And how do you manage approaching the standard guidelines with these parents?
I start by acknowledging their concerns as valid based on the data. I explain that while stimulants are highly effective, we titrate for a reason to find the maximum benefit with the lowest possible side effects. I also emphasize that the guidelines require us to screen for comorbidities like anxiety or learning disabilities, which often change our treatment priorities. If they are still hesitant, that's when we open the door to the complementary part of the conversation.
Based on research, we have found that there are many complementary and alternative therapies for ADHD, including implementing meditation, yoga, and deep breathing exercises. Some research also looks at dietary evidence eliminating junk foods and food dyes, especially red dye. Other articles suggest certain supplements may be effective, such as zinc and iron, vitamin D, magnesium, and omega-3s. But what does this data really show about these therapies, and how does it compare to popular alternative therapies?
FDA-approved stimulants like methylphenidate and amphetamines have the strongest evidence base, with a robust effect size of about 1.0. They work for about 70 to 80% of all patients. Non-stimulants like atomoxetine or guanfacine are effective, but have a slightly lower effect size of about 0.7, working for about 60 to 70% of patients. None of the non-stimulants are approved for preschool-age children. Parent training and behavioral management are recommended at first line for preschoolers, but is highly effective for all children in addition to their medications. Most studies comparing behavior therapy to stimulants indicates that stimulants have a stronger immediate effect on the 18 core symptoms of ADHD. Parents, however, were more satisfied with the effect of behavioral therapy because it addresses overall function and social skills. The positive effects of behavioral therapy tend to persist, but the positive effects of medication cease when medication stops. From research, it shows that most frequent CAM includes mind-body practices such as meditation, 10.8%, yoga at 9.6%, and deep breathing at 7.3%. The literature suggests that meditation improves cognitive efficiency and executive functioning. For an ADHD brain, the ability to focus on the present moment helps with inattention while learning to respond rather than react, and that helps with impulsivity. There's even evidence that meditation can increase dopamine release in certain brain areas, which is exactly what stimulants aim to do. Dietary restrictions are also massive, ranging from the DASH diet to the few foods elimination diet.
So, what would you suggest to parents as they try to navigate treatment and maybe open to both medications and alternative therapies?
I explained that conventional meds are excellent for immediate symptom control, but behavioral therapy and CAM often address the whole person and long-term skills. I use the AAP guidelines as the spine of the treatment and add CAM as limbs to support specific needs like sleep or anxiety.
I like that approach of considering how we can combine both treatment modalities. Let's move on to looking at the dietary evidence. We hear a lot about junk food and food dyes nowadays and how they can affect children's behavior.
Recent meta-analysis show that Western or junk food patterns high in refined grains and sugar increase ADHD risk by up to 51 to 92%. Conversely, a DASH diet rich in fruits, vegetables, and low-fat dairy is negatively associated with symptoms. The diet is rich in magnesium, calcium, and vitamin C, which may support the reduction of ADHD symptoms. By focusing on whole foods, the DASH diet naturally reduces the intake of processed ingredients, artificial colors, and sweeteners, which are often associated with worsening hyperactivity. Regarding artificial food colors, data suggests a small but significant deleterious effect on behavior, which is actually a general public health concern, not just for ADHD.
So what you're saying is it sounds like we could all benefit from a healthier eating pattern and a reduction in artificial food dyes.
Exactly. Some studies show that eliminating artificial food colors can benefit about 1/3 of children with ADHD. Beyond elimination, we see evidence for micronutrients. For example, zinc and iron are cofactors for dopamine production. If a child is deficient, supplementing can improve symptom severity. Vitamin D and magnesium have also shown promise improving emotional and social indices.
So, here's a question on safety. If a parent wants to start multiple supplements, zinc, iron, vitamin D, and omega 3s, while on medicine to treat ADHD, how do you manage that integration?
Safety first. I don't recommend blind supplementation. For vitamin D, I will check a baseline level. The evidence shows that kids with sufficient levels at the start don't see extra ADHD benefits from more vitamin D. For iron, we have to be careful with toxicity. I use these requests as a chance to order labs. If parents seek out more extreme elimination diet, such as few foods or the oligo-antigeneric diets mentioned in the literature, I warn them that these are highly restrictive and can lead to nutritional deficiencies if not strictly supervised.
As providers, how can we integrate both CAM and standard treatment of ADHD safely? There is often a communication gap. In the 2012 NHIS data showed that less than 1/3 of parents disclosed their child's CAM use to their doctors.
Many times, this is because a provider didn't ask. We have to normalize the conversation. Just as I ask about allergies, I now ask what vitamins, herbs, or mind-body practices are you using at home. We must respect patient values while being the evidence filter for them. If we are dismissive of CAM, they won't tell us, and that's when safety risks happen. As stated before, my goal is to use the AAP guidelines as the spine of our treatment and then add the limbs, the yoga, the specific dietary changes, or the omega 3s, based on the child's unique profile and the family's preferences.
Okay, great. And we have one final question before we wrap up the podcast. How can providers and families evaluate what works best for an individual child?
The key is titration and objective monitoring. The AAP guidelines recommend starting at the lowest dose and adjusting for maximum benefit with tolerable side effects. I use standardized tools like the Vanderbilt scales to get feedback from both parents and teachers. We also have to look at the whole child through school-based services like IEPs or 504 plans to ensure their environment supports their treatment. It's about a written management plan that is a living document updated as the child grows.
Well, thank you so much for joining us today for this podcast. It was very informative. Is there anything else that you think is pertinent to add that you've experienced from your personal practice?
I'd just like to reiterate that looking at the whole child is the most important part of treating any child with ADHD, and looking at the family and their preferences as a whole. It really has to be the whole family receiving treatment for it to be successful.
I really appreciate you providing that extra insight for us. It just shows that the path doesn't have to be one or the other, but can be safely integrated to support both clinical evidence and the family values. Thank you for joining us for our podcast today. I'm going to go ahead and upload the references we used for this. Thank you.